Hello, Aidan here. Today we'll be talking about joint play and its restrictions. This is taken from Len Fay's book, Motion Palpation and Chiropractic Technique. Joint play and its restrictions. In addition to the normal, active and passive ranges of motion, there's a third type of motion called joint play. This is a small but precise accessory movement that occurs within synovial joints and cannot be influenced except passively. Although joint play is necessary for normal joint function, it is not influenced by a patient's conscious volition. Thus, joint play can be defined as that degree of end movement or distension allowed passively that cannot be achieved through voluntary effort. In other words, total joint motion is the sum of the voluntary range of movement, active and passive, plus or minus any joint play that is exhibited. Joint play occurs because normal joint surfaces do not oppose tightly. Because joint surfaces are of varying radii, movement cannot occur about a rigid axis. The capsule must allow some extra play for full motion to occur. In addition to translation and rotation joint play, a degree of distraction within each joint must exist. If any one of these involuntary movements is impaired for some reason, the articular surfaces will become closely packed or compressed. Motion will then be restricted. If we add into this the fact that there are small spaces created by articular incongruence, which is necessary for hydrodynamic lubrication, then we can see that prolonged compression would lead to poor lubrication and possibly ischemia. Left long enough, this would likely progress to degenerative joint disease due to abrasion irritation. Now, joint play cannot be produced by phasic muscle contraction. However, voluntary muscle action is greatly influenced by normal joint play. The loss of joint play results in a painful joint that will become involuntarily protected by secondary muscle spasm. Therefore, motion palpation done to detect a restricted joint play is an important part of the biomechanical examination of any painful and spastic axial or appendicular joint. Pain and spasm results when a joint is moved either actively or passively in the direction which normal joint play is lacking. Once normal joint play is restored, the associated pain and spasm will subside. And joint play, of course, should exist in all ranges of movement that are normal for that particular joint. That is, if a joint functions in flexion, extension, abduction, adduction, the integrity of joint play in all these directions plus distraction should be evaluated. And of course, we find it is not unusual for joint play to be restricted in some planes, but not others. A very common cause of articular fixation and the resulting motion restriction is disuse. And we find, as I'm sure you will know, many occupations that require that certain joints move only in one or two planes, but not all of the planes that are available to that joint. For example, a joint that is continuously flexed but rarely extended will exhibit normal or abnormal joint play in flexion, and frequently restricted joint play in extension. A very similar situation will occur in a joint that is frequently abducted but rarely adducted, or frequently rotated towards the left but rarely to the right. This leads us to emphasize the importance of freeing articular fixations, for example, by chiropractic adjustments. Normal muscle function depends on normal joint function, and normal joint function on muscle function. If joint motion is not free, the involved muscles that move it cannot function and cannot be restored to normal. Thus, impaired muscle function leads to impaired joint function. Conversely, impaired joint function leads to impaired muscle function. This, of course, leads to a clinical cycle where muscle and joint function cannot be functionally separated from each other. In summary, Dr. Fay emphasizes the following major points of joint play. Number 1, total joint movement is the voluntary range of movement plus or minus the joint play present. 2, voluntary muscle action depends on normal joint play, but voluntary motion and exercise cannot produce or restore joint play. The presence or absence of joint play can only be demonstrated by an external examiner, that is, passively. Number 3, loss of joint play produces pain on testing, that is, whenever that direction of joint play is challenged. And when restricted joint play is restored by manipulation, the related pain will abate. A painful joint produces secondary muscular changes, or spasm, which is nature's way of preventing injurious joint movement. If painful joint movement occurs because of a joint play restriction, then the joint play must be restored to near normal to obtain a permanent reduction of that equivalent spasm. Number 4, muscles that move a joint which has joint dysfunction can become hypertonic in response to the pain from that joint's irritation. Therefore, the active range of motion at that joint is also restricted. Number 5, joint play can only be restored by an external mobilizing force, maneuver, thrust, impulse, which is delivered satisfactorily and in line with the plane of articulation and against the motion resistance or fixation. Dr. Fay makes some clinical comments. Number 1, the pain experienced by the patient when joint play is restricted is sharp and only lasts as long as the doctor presses into the restriction. This must not be confused with the joint pain associated with an inflamed joint that produces a more lingering type of pain when challenged. Number 2, we must remember that ligaments are never tender unless they are in a pathological state. We can experience trauma far less than that causes a fracture or dislocation, which can produce an inflammatory reaction similar to that caused by a bacterial invasion. Remember, the reaction to a bacterial invasion is designed to contain and wall off the invaders to prevent further spread of the infection. Therefore, after physical trauma, localization serves to contain the products of the injured tissues. Unfortunately, this can lead to resolution of inflammation or or scarring, which can be especially harmful if the joint has not returned to normal mobility. This will occur because normal periarticular soft tissues are flexible, elastic, plastic, and generally richly vascular, whereas scar tissue, on the other hand, tends to be more stiff, unyielding, and in fact poorly vasculated. For this reason, re-injured joints that were not properly attended to initially are extremely slow to heal. Now, in our lifetime, every individual has sustained numerous bumps, strains, and sprains within that period. And acute inflammation can develop into chronic inflammation that may in fact continue for decades. Therefore, it is necessary to treat each physical trauma until all pain, tenderness, swelling, immobility, etc., are eliminated. Partial treatment is not adequate for this, and your diagnosis should be accurate and comprehensive. Remember that more than one tissue is usually affected by a single traumatic incident, and the treatment should be specific for each tissue affected. Determining the cause of this trauma is not often an easy task. For example, tender, hypertonic perivertebral tissues found in the upper thoracic region of the spine could be from 1. Overworked tissues, for example, unaccustomed activity of chopping wood or shoveling. It could be from 2. Unusual sustained postures, for example, prolonged spinal extension as in painting a ceiling. 3. It could be a viscerosomatic reflex, for example, as a result of heavy smoking, lung or heart disease. 4. It could be due to excessive compensatory segmental hypermobility owing to one or more fixated lower cervical or mid-thoracic vertebral motion units. Or 5, it could in fact be a combination of 2 or more of these factors. The basic direction of your case management can be considered as progressing through 2 phases. The first goal is to reduce the swelling and relieve the associated pain and soreness by RICE, rest, ice, compression and elevation, or other physiotherapeutic measures where appropriate. The second objective is to promote healing and movement. We do this by adjusting, massage, stretching, passive exercise, active exercise, and other standard regimes. It's also important to relieve any attending neurologic disorder in the spine, as this often cuts the reflex feedback cycle that facilitates prolonging the effect, and also eliminates a possible source of a secondary or contributing subluxation complex. On our course, what we aim to do is show you how to assess not just active, not just passive, but joint play. Thank you for your time. Hope you enjoy watching this video and it's given you some insight. Please don't hesitate to hit the like button. We'd really appreciate reading your comments and thoughts on this video, and look forward to seeing you at the next video soon. Thanks for your time. Bye-bye.